Travis. Michaela, do you have anything before we get started?
Nope, I think we're good. There will be a survey at the end though, so once the Zoom ends, please answer the evaluation that will be pop up at the end. So
Perfect. And just like any other course that we've done is if you have questions throughout, you can put those in the chat box, or I'm sure the presenters will leave some time at the end for questions as well. So I'm not sure I'm going to be on at the end. I have another commitment that I might be here, but I may have to go to. So if I'm not on, Michaela, you'll take care of anything in the chat box. Awesome. Sounds good. All right. So without further ado, Dr. Owens and Travis.
Yeah, go ahead, Michaela. Okay, why don't we go back to the previous slide? Good evening. I'm Dr. Owens in Redfield, South Dakota, and putting together this webinar was kind of interesting. It brought back some interesting memories. Back at the beginning of COVID in January of 2020, this group, this organization, Northeast AHEC, etc., set up a training program via webinar in order to train EMTs to get some good information out about PPE and that sort of thing. And it's just grown from there. And I think this is quite a good program. I have just a few, it's going to be kind of a hodgepodge tonight. I'm going to kind of do the state of the state, I guess you would say, of rural EMS and what the South Dakota Medical Association, South Dakota USD Sanford School of Medicine, and the AHECs are doing to support you folks out in EMS land. And so we're going to start talking about rural EMS and farm emergencies. But first, we're going to talk about the state of rural EMS and what has changed over roughly the last year. Next slide. So the state of rural EMS shows that about 73% of rural EMS agencies use volunteer labor. And this is how we staff the agencies. So as you well know, this is not a high-paying field. For example, my wife is an RN and an EMT, and I brought this up multiple times with the medical school and the SDMA, the Medical Association. $2 an hour is not exactly a wage. So we are currently with an older model where we had, and we'll talk more about this along the line, where we had volunteerism running the program. And I'm here to say that that model is going to have to change. Next slide, please. So this data was obtained, looks like to me, in about 2018. So this is the workforce information as far as age. I would offer to bet that if you just added 4 years to this demographic, you'd probably pretty much define where we're at right now. 60% of EMTs at that time were 45 or older, and more than 50% in all 70 regions across the state. So for a long-term plan, nothing against people over 45. I happen to be above 45, but that's just not a great long-term game plan. Next slide there, Michaela. So one of the things that's resulted, and I think this is one of the things that really got the South Dakota Medical Association and the med school quite interested, is this data right here is very concerning. During 2015 to 2016, and I would pretty much say I don't think it's gotten a whole lot better, that up to a third of agencies reported that they were not able to respond in time or at all due to lack of staff availability. That's something that I find quite concerning, especially as I drive across the state knowing that you already have a geographic problem as far as getting to me if I'm in a car wreck or I'm having chest pain or that sort of thing. Go ahead, Michaela. So basically what happened was a group of people representing multiple different systems worked with USD Sanford School of Medicine, along with the South Dakota Area Health Co-ops and Redfield Community Memorial Hospital. We applied and received a U.S. Department of Labor grant for training rural EMS. We then partnered up with USD Sanford and Sanford Health Center for Pre-Hospital Care and Simulation. And as of approximately this week, and Travis, you can jump in and correct me, but we have about 240 new EMTs about ready to be rolled out. I think we've already got 120 have tested out, and now we have 240 candidates that were brought to us via both a hybrid virtual course, in-person courses like we've done here in Redfield and other places, and also the dual credit course opportunity for high school students. It is my goal, and the reason why 240 is not enough per year, is my experience doing rural medicine and being the EMS director is when you bring new people on, and I think a lot of you folks will agree with this, a lot of your folks, as they've aged and done it for 20 years, basically will kind of roll out and retire from the volunteer service. So we've got to recruit and train more EMTs, not only to bring us up to a full troop strength, but also to cover those folks that want to go to less call or no call. Basically, then also as a subcomponent of this, out in Tripp County, they've done a similar thing with EMT education, working with Sanford Health, with the support of the Sanford School of Medicine. My personal goal is that in 2022, 2023, we double that 240 and try to get it north of 400. Next, Michaela. So in order to get this done, a unique and very interesting program, and if you want to learn more about it, just Google, or maybe we can make an attachment. We set up what was called a Dakota Responder Program. And what I was looking at was rural data. What life-saving interventions can be done by somebody that's not fully trained as an EMT that can change outcomes? So through a variety of connections with AgTegra, which is, I think, the largest ag co-op in the Dakotas, they have about 9,000 members. They were willing to pay, and this is quite important, the full salary and the full travel time, expense, etc., for 130 employees to take the Dakota Responder course. So it has a twofold mission. Mission one is to get some life-saving intervention training out to these folks that are all over rural South Dakota. And number two, use it as a recruiting ground to train more EMTs. So the training includes Stop the Bleed as defined by the American College of Surgeons Committee on Trauma. We also go through the state required training so that people can give Narcan. And then we also go through the proper use of the automatic external defibrillator. As part of that grant, we were able to get a number of Stop the Bleed kits, and we've positioned them, I think, in about 60 different vehicles that are out on the road on any given day around South Dakota and actually somewhat into North Dakota. The Narcan and the EDs are kept at their local sites. Now, of note, as this program expands, the superintendent of schools here in Redfield sent out a questionnaire across the state of South Dakota, and we found that 60 out of 90 school districts are interested in having the Dakota Responder Program presented at their schools for their teachers, employees, etc. Okay, next slide, please. And the thing, when you develop what's called a beta test, we're checking to see if this really does work. So the first 101 participants filled out a form, and up to a third of them have a definite interest in taking either EMT training and or possibly emergency medical responder training. Additionally, 100% across the board believe that the School of Medicine should offer this training across rural South Dakota. And if you look over on the right, as far as the confidence quota, it's really quite good, I think. Increased confidence, ability to respond to medical emergencies, better confidence in Narcan, better confidence in Stop the Bleed and AED. As you can see, that was in conjunction with Agtegra, the co-op, and the medical school in Redfield Community Memorial Hospital. Thought those were pretty good testimonials. Next, Michaela. That's the footprint of Agtegra. Those are the locations of their sites. They're actually providing ag services over a much larger range. Next. So what's good for the gander is good for the goose. So as a part of this whole interface between USD Sanford School of Medicine and Agtegra, I asked if they would be willing to help train some medical students. And here about a month ago, we took 7 Frontier Rural Medicine medical students who planned to practice in rural South Dakota to a critical response training event in Warner. And as you can see on the second picture from the left, that is a dangling future doctor. Note the scrubs. And I think that level of training, I think we've just started to see the beginning of how we integrate ag training back to the med school and med school training back to the ag sector in South Dakota. Once again, the students volunteered to be part of the operational portion of that training team. Next. So why is rural EMS different? We've already talked about it's volunteer driven. The other part that's really playing a large role is the aging of our communities. Our people are getting older, they're having more medical problems. We've seen a decrease in access to health care. We have a much longer transfer distance in time simply due to geography. You compare a transfer time, let's say in Minneapolis, Sioux Falls, or Chicago, some of our folks are needing to go 100 miles just to get initial stabilization. Additionally, we have unique exposures, things like green bin entrapments, chemicals, etc. And that's the view off the top of Warner's green bins. I believe that's looking west. Go ahead, next. And this is something that should catch everybody's eye. This comes from the South Dakota Department of Health, and this is what's called a mortality. It doesn't talk about morbidity. Remember, morbidity, I got hurt, I got sick, but I recovered. Mortality is the person died. Look at the average number of ag-related farm accident deaths. Pretty amazing. And early intervention, life-saving intervention, maximizing EMS and rural EMS, I think are going to be a key to dropping those numbers. Go ahead, next. So real quickly, as Kyle mentioned, got a lot of things burning out here, and the take home from my side for the medical aspect of it is you may want to have your teams review quickly the rule of 9s or 8s for burns. And one thing to take home to really think about is we're all familiar with the SAT-O2 monitor. So this has more to do with that pre-hospital stage. If you have a patient that has been part of a fire, a burn, or explosion, Two things to remember. Number one, if you notice that their nares or up in their nose has burning or soot, you need to notify the hospital that you're transferring to, because that is a very bad sign. That may be more life-threatening than it looks in the present time while you're seeing that patient. The other thing is, if you have a SATO2 monitor on somebody that's been in an inhalation system situation, don't trust it. Remember, a SATO2 monitor, it only monitors if the hemoglobin is occupied. It does not tell you if it's carbon monoxide or if it's oxygen. So if in doubt, and you have somebody that either has burns or inhalation, get them on some oxygen, pretty good flow too, get it running. Next. The other thing to think about, especially as we're working through into the harvest season, review your equipment that you can use for entrapment. And as far as structural entrapment, I do know that the team that Agtegra has responded to non-Agtegra facilities. But as an EMS, you need to look at just a quick go-through of your equipment, your jaws, etc. I don't believe a lot of EMTs are trained for extrication in bins, but depending on your level of service, it's that time of year to go through your equipment. Next. And now I'm going to turn it over to Mr. Travis Spear, educator renowned, for a talk about crush injuries for EMS.
Thank you, Dr. Owens. We'll go ahead and look at crush injuries or crush syndromes as they apply to not only agriculture industry and even I think in the special needs populations. And so you ultimately start with that injury and then it leads into a syndrome, and the overall impact of the overall event comes into play. So next slide, please. So when we look at just the simplistic definition of the syndrome itself, and I think, when you look at physiology of the body, you have to look at it from a cellular standpoint. You have to look at it from the basis of the smallest tissues possible. As we work with individuals, as we're teaching EMT classes, we always emphasize that if a cell dies, the surrounding tissue dies, or surrounding cells die and surrounding tissue dies, the tissue that makes up the organ dies, the organ that makes up the organ system dies. If that one organ system fails, then we're going to generally identify there's going to be other organ systems that fail because of that as well. So when you look at the crush syndrome, there's a multitude of things that are happening at a cellular level, happening to the tissue. And this is all kind of related to poor perfusion, poor circulation, the inability to remove waste products. And so the injuries themselves, as I mentioned before, can be agricultural related. We see industry related incidents as well, construction site accidents, trench collapses, but also these types of crush injuries, crush syndromes can also be simplistically related back to medical events with individuals that are in a position for a prolonged period of time. Now, when we look at this, things that we need to consider are what is the extent and kind of the overall impact of the injury itself. We look at the overall duration that the individual has been compressed or that tissue has been compressed, the amount of force that has been applied to this particular individual. Just the weight of one's body can cause these types of injuries. We see this in patients, elderly patients that fall in their home, morbidly obese patients that are in a precarious position for a prolonged period of time. The weight of their own body can cause, these types of injuries. It's not just, that they have to be crushed by a truck or a tractor or a heavy piece of equipment. It's the simplicity of positioning, and then even the simplicity of their own patient's body weight. When we look at their health, we have to understand Age comes into play. Other factors that come into play is comorbid factors or their underlying health issues. And then also, I think the important piece is we look at the geographical area that we reside in South Dakota. It also applies to the environment that we function or work within and how we're going to find these patients. So as the harvest continues on into the fall, temperatures start to decline as we get into harvesting corn and getting into October and snow starts to fly. Prolonged exposures, prolonged entrapments, hypothermia can come into play as well. Next slide. So when we look at the crush injury itself, that's kind of the premises of what is happening. That ends up ultimately leading into the crush syndrome. So we look at the direct injury from the crush. Most commonly, we find that it's in the appendages of the body. So arms, legs, realistically, it could be even as simplistic as fingers and toes, those things. We also get into the torso of the body based upon how the individual is compressed and how that injury is actually taking place. The other thing too that we need to account for is the crush injury is taking place. So something is getting squished or squashed. As that portion of the body is getting squashed per se, the underlying tissues, simplistically the cells, the tissues, the muscles, the fat, the vasculature, the nerves, all of that stuff is being damaged from the initial injury itself and the prolonged compression that's actually taking place. If you think, if you've ever been in a seated position for a prolonged period of time, or if you've, slept on the couch or slept in bed and you have your arm or leg in an awkward position, sometimes it causes compromised blood flow. And so you have this tingling sensation that occurs in the extremity because of that compromising position. And so in the same token here is that something is compressing the appendage, the extremity, the body, the torso, and it's preventing adequate blood flow from getting pumped out to the extremities and also the return of blood flow back to the heart. And so when that lack of return of blood flow is occurring, it's because there's some type of an occlusion or restriction that's preventing that blood flow from coming back. And during that particular time, all of that blood becomes stagnant. Some of the toxins start to build up in the extremities because the body's no longer able to use oxygenated blood as a source of energy. And so what ends up happening is you have this kind of stagnant toxic blood that's sitting out in the peripheral areas below the compressed area. And so that is also a portion of the impact that's happening to the body and these crush syndromes is not only the injury of the crush, but it's also the stagnant blood that's sitting there. Next slide, please. So, as this particular picture can demonstrate is, yes, this is applicable to ag-related types of situations. And so then, in the middle slide, this could be, something as devastating as a natural event or, a crushing type of an injury from a structural collapse, as you can see in the bottom right-hand corner from a bridge collapse. I did this presentation up in Mankato 2 weeks ago, and the validation and verification that even with the 35W bridge collapse up in Minneapolis, they had crush-related injuries. I know there was a incident a couple of years ago in Sioux Falls where there were crush-related injuries associated to a building collapse. There's been trench collapses that have occurred. There was recently a building collapse up in the northeastern portion of the state. And so anytime you have these types of situations that are taking place, it could be even a prolonged entrapment in a car from a motor vehicle crash. And so there's a multitude of causes that can contribute to the symptomology, the situation, and then the consequences from the injury itself, and then also the syndrome. Next slide, please. The other thing that, like I mentioned before, is that we have to account for the environment that we work in. And so as you can see here, a building collapse, a significant amount of snow. I believe, several years ago, there was building collapses out on the Black Hills because of a heavy snow load that occurred, over a couple days. And so when we look at that, you have individuals that are in a precarious position crushed or stuck basically in a position underneath rubble for a prolonged period of time. And then that's kind of compounded by this cold environment that they're in as well. You know, one of the things that we teach in the EMT classes and we emphasize to responders is that, you know, the simplicity of somebody falling in their home, you know, with a household temperature of 72 or even 74 degrees, an individual in a mobile position for a prolonged period of time, even 12 hours, can become hypothermic. They can suffer some of these types of compression types of events. The other thing, even more simplistically, is if you look at, there's been a greater or even higher emphasis from emergency departments for prolonged immobilization of patients that are coming into the ER that are on backboards. Is the emphasis to try to get these individuals off the backboards as quickly as possible, because there's tissue and breakdown that's occurring, but again, by the weight of the body, compressing forces on that tissue, bony bony areas of the body that's causing tissue and cellular breakdown. So when we look at it, is yes, it could be the time of the day, it could be the time of the year, it could be, you know, winter type a type of temperature environments. It could be somebody that maybe is exposed to water where they're you know, wet. They could be partially submerged into water, and the cool temperatures of the water can contribute to the situation as well. So all of those factors need to be taken into consideration when you're managing or dealing with this type of a event. Next slide, please. So this is just kind of an anatomical cadaver cutaway of a lower extremity that takes into account the bony structures, the muscular structures, the vasculature, the fatty tissue. And so what happens is, you know, generally speaking, if you grab your leg, if you grab your arm, there's a little bit of give there. There's a little bit of cushion there. And so as these types of injuries take place, the compressive forces ends up causing inflammation, tissue swelling, to occur. And generally, we can accommodate that tissue swelling as the tissues proceed to expand. That swelling starts to take place, but ultimately you get to a point of maximum expansion, kind of a maximum swelling capability that's able to occur. So if you even more simplistically look at it, is you take a can of pop or a bottle of pop and you shake it up, a carbonated beverage. Initially, when you squeeze that can or you squeeze that bottle, there's a little bit of give to it. But after you've shaken it up, that carbonation, the release of gases, causes that container to be extremely tight, and the carbonation is accounted for all of that potential extra space. Well, the same thing happens to the extremities. Is if there's a decreased amount of blood return from the extremities, the tissues themselves start to swell up for a prolonged period of time. You can get necrotic tissue that ends up occurring as the tissue is compressed against itself, as the tissue is compressed against the bony structures. So all of these things come into factor. So a lot of times when you have some type of a crushing injury, clinicians will look at it as, you know, or consider, is this a compartment type of syndrome that's occurring, you know, where the extremity itself has reached maximum swelling capacity, and all of a sudden the swelling starts to pressurize or push in on the internal structures, damaging those internal structures, the vasculature, the muscles, the fatty tissue, the nerve endings. And so then we end up getting numbness, decreased perfusion, decreased circulation that ends up occurring with that injured or compressed extremity. Next slide, please. So the other thing that comes into play is when we look at these compressive forces on a particular extremity, generally there's also association with some type of soft tissue injury that ends up occurring. The other consideration that we need to account for is that if there is a profound compression of the extremity and there's a lack of blood return to the body, there's all this stagnant toxic blood sitting below the compressing force. And so if we were to lift that particular compressing force off of the patient, off of that appendage, off of that torso, that stagnant toxic blood is going to return back into circulation. That toxic blood is inclusive of clots, it's inclusive of acidotic blood, it's inclusive of damaged, you know, per se, or toxic plasma. It's been a breakdown of tissues. All of that stuff is being reintroduced back into the vasculature of the body. That in itself can be compromising to the livelihood or the the physiological state of the body, of the physiological state of the patient, and in itself can cause the patient to succumb from cardiac arrest or die from compromising components. So the use of the tourniquet comes into play. And so, again, sometimes we see where people have soft tissue injuries that are inclusive of arterial bleeds where a tourniquet needs to be applied. Sometimes it's in regards to a soft tissue injury that has venous involvement, and there's inability to control bleeding through traditional methods of direct pressure dressings. And so that use of the tourniquet comes into play. One of the emphasizing points to make is that we see a lot of patients coming into the emergency departments with tourniquets. A lot of times those tourniquets are inappropriately applied because they're just fairly simplistic wounds where probably direct pressure dressing would have taken care of the bleeding. And so just, again, making sure that when you're trying to optimize bleeding control and the application of a tourniquet is being applied to an appendage, one, it's on a single bony structure, high and tight, so such as the thigh or the femur, or in the humerus in the upper arm. That's where you would be applying that particular tourniquet to help control the bleeding. Again, if it's life-threatening in volume and capacity because it's a large pooling of blood from venous blood loss, or if it's arterial in nature, then the consideration to put that tourniquet on. Next slide, please. Non-traumatic conditions, as I mentioned before, sometimes you have people that, elderly patients that maybe fall and break a hip, they lay on their floor for a prolonged period of time. Maybe it's a patient that has a stroke. It could be somebody that had a syncopal episode. It could be somebody that was assaulted and is in, again, an awkward position for a prolonged period of time. We find that there are people that, patients that are intoxicated or under the influence of illicit drugs that are in a immobile position for a prolonged period of time. And these individuals themselves can succumb from these compartment type of compressing types of forces, again, just from the weight of their own body. The immobility is causing or preventing that tissue breakdown, the cellular death, and again, impending or impacting the return of spontaneous blood flow back to the cardiovascular system. Immobility, again, for timelines. Sometimes, I've seen patients that come into the ER that have been on a backboard for an hour or less, 20 to 30 minutes, and based upon the amount of fat structure, the muscular or the body tissue structure, if it's an elderly person and they don't have a lot of body mass, those bony prominences can start to cause tissue breakdown just laying on top of a backboard. And it's not just the elderly. I recall a 20-some-year-old individual that came in from a motor vehicle crash that was on a backboard for about 2.5 hours. And that healthy 20-year-old individual ended up having tissue breakdown just from prolonged immobilization on a rigid backboard. So again, it's just something to take into consideration. Next slide, please. So when you look at the expansion, kind of swelling, compartment types of syndromes that can take place, you can see here just the swelling that takes place, and sometimes the tissue itself will tear, rip open. Sometimes the appendage or the extremity will have some type of a soft tissue injury that also promotes the tearing of the tissue. But if that release of pressure does not occur, that continued in pressure starts to push on the internal structures. Now, and as you can see in the bottom left-hand corner, this is somebody that's pinned underneath some rubbish and likely for a prolonged period of time until they can be appropriately extricated. And so when we look at these particular appendages, when there's compressing types of forces or compartment syndrome that takes place, we have to look at, does the patient have pain? Do they have numbness and tingling? Is there perfusion? Is there pulses? What's the color? So we look at that very appropriate CMS assessment, PMS assessment of the peripheral extremity to kind of help us determine how much vascular, neurovascular involvement has taken place. Next slide, please. So some of the kind of metabolic and physiological things that end up taking place is that you know, this acidotic environment starts to occur because there's a lack of oxygen and blood supply going out into the periphery, into the tissues. And so lactate starts to accumulate. There's a tissue breakdown, and it causes a release of lactate as well. We look at an increased amount of potassium developing because of the compressing forces out in these tissues, and they can become extremely high and almost life-threatening. There's vascular breakdowns, the promotion of clots because there's stagnant blood sitting in the periphery. We end up with either some vasodilatation or bronchial constriction that can take place, again, from just a histamine release. And so these are just some of the physiological things that can happen with prolonged compression and compression syndromes. Next slide, please. As I emphasized before, just the consequences of the crush injuries itself. The injury itself can be associated with these soft tissue injuries the tissue injuries themselves can lead to hypovolemic shock and blood loss. If we look at certain situations, again, from the compressing force, the increase in potassium buildup in the vasculature can cause life-threatening arrhythmias to the heart, sometimes cardiac arrest. The injury and insult of these toxins being filtered out through the renal system, rhabdomyolysis, and you know, blood clots in the urine can lead to damage to the renal system. Hypotensive events can cause and lead to damage to the renal system. So in certain circumstances, you know, again, through a couple different studies, you know, there's some that promote the use of a tourniquet and compressing forces. There's others that do not. But nonetheless, is that we do want to try to limit the amount of stagnant blood that's reintroduced back into the vasculature if there's been a compressing force on an appendage for a prolonged period of time. And so then the application of that tourniquet to a proximal extremity so that it's high and tight, and it's reducing the amount of potential stagnant blood loss that's being reintroduced back into the body. So that would be a considering circumstance to be able to apply these tourniquets for non soft tissue types of injuries. Next slide, please. So when we look at these different types of situations, you know, and just different events that have occurred. So the top right one is the Oklahoma City bombing. The bottom left one is 9/11 in New York City. And then you look at the bottom right one for the I-35 bridge collapse up in Minneapolis. Now, our management and approach to this is going to also be dependent upon the scope of practice that we are. And so just looking at the list of participants tonight, I can see that there's a variety of ALS providers and BLS providers that are on the call. From the BLS perspective is understanding the circumstance that you're in, identifying the transport distance and duration that you're going to have with that particular patient once they're extricated from the situation, and then accessing or tapping into your resources, whether it's availability of ALS resources for ground paramedics, or if you're requesting air medical transport to come in to help expedite the transport of that patient to a trauma center. It's just looking at the circumstance and situation and using time to your benefit. Is if you know you have that prolonged extrication, you know that you have a patient that's meets the criteria of a crush injury or a crush syndrome, utilize time to your advantage and access and tap into those resources so that they're immediately available to the patient once they become extricated from the event. For the ALS providers, it's a multitude of things based upon your scope of practice, based upon your protocols. Your local medical directorship is what they're going to be able to provide, or what they're going to allow for you to perform in these types of circumstances. The placement of IVs, the administration of IV fluids, the administration of medications to counteract the hyperkalemia and try to fight off the acidotic environment of the blood supply. All of those factors actually come into play. The use of blood products as well, the recognition and understanding of comorbid factors, and then also any contributing injuries that might be taking place. And so it really does determine on kind of weigh on what your scope of practice is, what your local capabilities are. But again, more importantly, is as you look at these situations, they're generally associated with prolonged extrication times, you know, sometimes greater than 12 to 24 hours. You know, some literature that I was able to find, you know, emphasize that some of these crush injury patients, you know, retained signs and symptoms of life, for up to 10 to 14 days, based upon, ideal circumstances and environments. And so all of these factors, again, kind of weigh in on how your patient's going to do from an outcome perspective. Next slide, please. So again, just the most simplistic of injuries, such as fractures and, something that's causing compromised peripheral circulation. All of these things can actually lead into some type of traumatic ischemia to the tissues, and then again into a compartment syndrome type of circumstance or situation. And so again, the emphasizing point here is that communication is going to be key. Using time to your benefit is accessing and utilizing all of your resources. Keeping in communication with the hospital to let them know what's happening on the scene so that they can activate appropriate resources within their particular facility as well. Next slide, please. Any questions? Okay.
Anybody out there got any questions, you can put them in the chat box, or you can.
Travis, can I add on a few things? This is Dr. Owens.
Yeah, please, go ahead.
Okay, one of these things, think about this and what's happening right now in Florida. So when you look at nursing home evacuations, sometimes there's a lot of second guessing going on. Why didn't they evacuate earlier? On and on and on. Is actually evacuating elderly has a significant risk, both morbidity and mortality, because of pressure ulcers. In other words, you can't have elderly people sitting in the same chair for 4 hours without getting tissue breakdown, pressure ulcers, and some very, very tough outcomes. So think about that for your folks that are transporting older people, in that you're setting them up for pressure ulcers and a variety of even rhabdomyolysis, which is the muscle breakdown from immobility. That's why that idea of wearing a first alert button makes a lot of sense, because once most people that are over, say, 80 have some compromised renal function, and then if you start pouring in the breakdown products of muscle, anoxic muscle, you basically, that myoglobin acts like a protein plug in the kidney and plugs up the gloms, which are the filtering portions, and can put people right into renal failure to the point where they may require dialysis. As far as the pressure ulcer thing, I think we've all seen that. As far as compartment syndrome, back in the day when I was an EMT with in Arctic warfare, I actually saw some very fit, very well conditioned military folks develop compartment syndromes in the lower extremities from snowshoeing and cross-country skiing. And one of the things, if you have somebody in your family or whatever that's doing those sort of behaviors, if they ever get where they can't point their toes up and down, any evidence of toe drag, go right to the ED. That pressure has got to be relieved. The other thing you also see it with is in high school sports with direct trauma. The other thing, just as an FYI, so if you have somebody that has a crush injury and you bring them into the ED, and the physician or whoever is covering the ED asks for albuterol and an insulin drip, don't think they misunderstood and think that the person has diabetes and asthma. Those two drugs, obviously you got to drip in some glucose when you're dripping insulin, help drive that potassium back into the intercellular space so it's not toxic to the heart. In other words, if your potassium gets at a certain level, it will lead to cardiac arrest.
One of the cases I was going to share is I had an acquaintance of mine, and he was actually driving a sugar beet truck and that was basically his full-time job. And in the fall, obviously, they work long hours. His particular situation is he had insulin-dependent diabetes. He was morbidly obese. He had a very sedentary lifestyle, and he was driving a semi-truck that had a clutch. And about 8 hours into the day of driving the semi-truck and pushing in the clutch and switching gears and moving between the elevator and the sugar beet field, he noticed that his calf was becoming, extremely tight, very painful, and very tingly. And so at the end of the shift, he ended up going home. The pain became such where he was unable to manage it. And so late in the evening, after returning, from work, went into the ER, was seen, was sent home, came back a couple hours later, again, because of increased amount of pain, was ultimately sent on to another facility from a referral perspective. They saw him in the ER, discharged him, sent him back home, returned back to his hometown ER, and the hometown ER had recognized compartment syndrome developing when they saw him and referred him initially. So then ended up going back to the tertiary facility for management. And so he had compromised circulation for about 16 hours at time, and then ended up losing about 70% of his calf muscle and legs, and ended up going through several months of reconstructive surgery just because of something that was not assessed appropriately or managed appropriately. And so when you look at these types of situations, they don't always have to be a crushing, impinging type of situation. It could be, something as simple as sitting, as Dr. Owens had indicated, for the elderly people sitting in a wheelchair during an evacuation episode. It could be, somebody sitting in a vehicle for a prolonged period of time, somebody laying on the floor for a prolonged period of time. So just again, kind of keep your senses and up, and looking for these types of situations to occur.
Again, anybody, any questions for our two presenters this evening? Nobody. Well, I don't have anything else. Appreciate you guys.
We have some more slides to go through.
Very slow dial.
Whoa, I'm going ahead of myself. Sorry. Sorry, Doc.
We're all right. All right, so now the time for the advertisement. Nobody gets away free. So as we try to increase the amount of EMTs in rural South Dakota, working with Sanford School of Medicine and Sanford EMS, we want to take a look at a couple of course training options that you would have. And one of the things to think about is there is still grant funding applicable or usable for eligible individuals. Travis, you want to talk about the hybrid online course and the dual credit?
Sure, I'd be glad to do that. So as Dr. Owens had indicated, the city of Redfield has been extremely gracious with their grant award. And so the SAMHSA grant that they received provided funding for 110 individuals that live in a rural area of the state of South Dakota to be able to participate in the EMT class for free. Their other grant through the Department of Labor also provides grant funding for individuals to participate in the EMT course at no cost if they reside in a rural area. Now, obviously, the objective and the goal is to get individuals to take the EMT test, to get them to pass the EMT test, to get them to volunteer, work with a local EMS agency to increase the number of EMS responders that we have throughout the state. So one of the things that we identified, probably 10, 15 years ago is that the availability and convenience of accessing EMS education is generally through traveling somewhere or going somewhere to a particular course. And so we've been leveraging the use of technology since probably 2007 and televising the courses out very similar to what they're doing this evening. For the EMT class specifically, every Tuesday and Thursday evening, we televise a live lecture environment out to the EMT students from 6 o'clock to 10 o'clock at night. They're able to interact live, just like you're doing this evening, with the instructors that are teaching that particular class. There's one skills lab day that occurs per month. In the past, we've had all of the EMT students drive into Sioux Falls to do that skills lab day. And so we've had students as far away as Bemidji, St. Cloud, Rapid City, Bismarck, Fargo, that have participated, Des Moines, that have participated in the EMT course in the past through the live televised course, and then have attended the lab sessions in Sioux Falls on a monthly basis. One of the things that we changed up in January was that we transitioned the skills lab activities out to regionally located sites that we partner with ambulance services. And so in the spring course, we were able to partner up with Kadoka and Armor. I see that Nicole's on the call tonight. We were able to partner with Miller and Falkton. In Clear Lake, we were able to partner with them, and then also in Alcester, and then we continued to do the skills lab location here in Sioux Falls. For this fall course, we've got Phillip is a site that's hosting the skills lab activities. Nicola's been gracious to do it again in Armor. Sheila's been gracious to do it again in Clear Lake, and then we also have DeSmet as a site, as well as Sioux Falls. And so the goal is obviously with the state of the economy, finances, and everything, we're trying to prevent or kind of keep individuals out of pocket expense down as low as possible. And so the gracious, finances of the grant activities that allow us to be able to provide the EMT course for free. It also includes the National Registry written exam, the CPR certification, the skills lab activities, and then also the skills testing that coincide with taking the EMT course. And so again, for the individuals that are interested, it gives them an opportunity to take the EMT class at no expense, gives them the opportunity to take the National Registry exam at no expense. Now, the ultimate goal is to get them to pass the course, pass the National Registry exam, and then come back out into the rural communities and help increase the workforce shortages that everybody is kind of suffering from. So the simplicity of it is August was the conclusion of our Redfield SAMHSA grant, and so we'll be teaching out to students that participated in that particular grant activity. They'll graduate from the EMT program in December. We just recently were re-awarded another SAMHSA grant in partnership with Tripp County Ambulance in winter. And so that provides EMT education, free EMT education, again, very similar to the Redfield grant for individuals in 2023. Next slide, please. The SAMHSA grant specifically provides funding for high school students. So we've been doing EMT class in the high schools for 10 to 12 years in the Sioux Falls area. And so this basically allows us to take the EMT class statewide. We had 65 high school students take the EMT course in January, and it gives them the opportunity to take it during their senior year. The state of South Dakota still has restrictions on certification or registration as an EMT in the state, so they still have to be 18 years of age. The National Registry eliminated their age requirement about 2 or 3 years ago, and so there is no age requirement to take the National Registry exam, but there is an age requirement in the state to become an EMT. So we do operationally, internally for Sanford, we do require the individuals to be a high school senior, so either in their fall or spring semester of high school. Does require the school to actually sign off on the individual to participate in the high school EMT course. We've had participation and support through the Department of Education and the HOSA organization to promote high school seniors to take the EMT course. And a little bit differently than our televised online evening course is that the high school students have a dedicated 1-hour block that's provided by the school district or the high school for the individuals to actually work on their EMT course during the day, during their high school course period. And so they have that 1-hour or 2-hour block that they're able to work on the EMT course Monday through Friday. They're still required to attend the Saturday skills labs that occur each month. And then also if the individuals are interested, there is dual credit availability through Southeast Technical College here in Sioux Falls. The Regental schools have been allowing up to 3 college credits if the individuals pass the National Registry EMT exam and they bring in their National Registry certificate and registry card, the schools, the colleges, the universities have provided 3 college credits for those individuals that have taken and passed the National Registry exam. The dual credit piece is specifically for the tech ed schools, so it'd be Lake Erie Tech, Southeast Tech, Mitchell Tech, and Western Dakota Tech. And they will, from a Department of Education and tech school perspective, allow that credit to come into the academic program of study for those individuals. We do require that the individuals also get authorization from the parents. As everybody knows from having taken the EMT course, is that is a very rigorous course. It has high time and academic demands on the individual. And so one of the things that we do want to make sure that the individuals that participate and take the course, it's not compromising their high school courses and their high school studies. The EMT course will impact their overall high school grade and GPA. And so we've had some high school students in the past that are trying to take the EMT class along with maybe 3 or 4 other AP courses. And so sometimes it just becomes too time consuming for them, and they opt to withdraw. So we just want to make sure that the students understand what they're getting into when they sign up for the high school course. But our high school pass ratio in the past has been 95% of the high school students that have taken the EMT course and taken the National Registry exam have passed on the first attempt. And so I think, with that, the high school students are very familiar with the habits of studying and the rigor that goes behind academic coursework. And so we see been able to see a very high pass rate for those individuals. And it gives them the opportunity to, again, use the EMT course as a precursor entering into the paramedic program too.
Travis, this is Doc. Correct me if I'm wrong. This also is included if they want to go to SCSU, USD, or one of the other colleges. They can get general elective credits, I believe.
Correct.
Is that your understanding? Yeah.
Yeah. So we've
And it's a lot cheaper than, as a dad of 2 college students. This looks a pretty good deal. Mm-hmm.
Yeah. 30 years ago, when I had went to paramedic school, I was going to nursing school at the same time, and I transferred in my EMT course for 3 college credits with Jamestown College in North Dakota. And so that particular practice has been in place for a number of years. I know we've had students transfer in at USD. We've also had students that have transferred credits in at SDSU. We've had students that have transferred in credit out at the School of Mines. We've had out-of-state colleges. Dort is one that I had transfer in college credit for. University of Minnesota Moorhead was another one that transferred in college credit. So we've had worked collaboratively with secondary education for schools to be able to transfer in these particular credits. Now it differs a little bit on a dual credit piece. It's specifically through Southeast Tech. It's transferable into the tech ed schools. If they do not, if they're not going to one of the tech ed schools, then we have them and they want college credit for it, then they'll need to take the National Registry exam, pass the National Registry exam, and then the universities and colleges would then transfer in that college credit for them as an elective at no cost.
Want to go next slide? So basically, the support system for volunteer rural EMTs and non-volunteer rural EMTs and paramedics and whatnot is this really interesting compilation of groups. We have the South Dakota Medical Association, USD Sanford School of Medicine, and then we have the 3 AHECs across the state that also play a very significant role, not just in EMT training, but also in disaster preparedness. Next slide, please. So the Northeast AHEC, once again going back to January of 2020, has had 22 hours of CEU on the COVID issue. We've had 850 EMS provider hours 30 CEUs since December of 2020. The Southeast AHEC actually works with healthcare profession students. I'm the medical director of the Upper Basin Disaster Training Center, and we've been doing this for approximately 16 years, and we've produced over 5,000 medical students, PAs, OT, PT, speech therapy, nursing, etc., in basic fundamental disaster response training. And we have now expanded out to Mitchell and a few other places. And then both in commonality between the Northeast AHEC and the Southeast AHEC, we have 60 health profession students a year get into the AHEC scholars. Next slide. This is the mobile med school, Teach Mobile. But as you can see before, that heading is not actually correct. When you have dangling baby doctors, you have a med school that not only does not have walls, in that case, it didn't even have a ceiling. Next slide. And this is just a reminder that we've entered into the wonderful season of duck hunting. And as I volunteer my time and efforts towards EMT training, I'm also your go-to guy to call if you have ducks that you think may or may not have avian influenza. I will come and at no charge work with you on ameliorating that problem. I hope everybody understands that was a joke, but it is an attempt nonetheless. Well, thanks for your attention tonight, folks. Any more questions out there? One question I'd have for you folks is to think about those 60 out of 90 school districts that want to do that Dakota Responder. I may be calling your local agency because I may need some help once I get, if this comes to fruition where we get the time, money, etc., to pursue this, to come help teach that Dakota Responder class, specifically Stop the Bleed and the AED. And you may be able to recruit a few more people for your agency. Thank you very much.
All right.
Please,
Go ahead.
and if they could, sorry, Kyle, if you could please answer the poll, then we will pass that information on to Dr. Owens. And then also at the end, there will also be like a survey with questions on the evaluation part of this. That's all I have, Kyle.
Okay, do we have any questions for the presenters? I guess I just want to say thank you, gentlemen, for presenting tonight and for your efforts in what you've been doing in the last number of months to combat this issue of our shrinking EMS workforce. So I appreciate it a lot. And I appreciate you guys, kind of just grabbing on and digging in and putting together the programs that you guys are putting together. So very much appreciated from me, and I know others as well. So I continue to answer those questions that are in the chat box or that are on your screen. Be greatly appreciated. And then also, again, last call for questions for tonight for these two outstanding instructors.
Kyle, this is Nicole. I just want to also express my thanks for the program and the training and stuff. And yes, like Travis said, we have been a site. Now we're on our second group of students. And if anybody is interested at all, it is a great program to get people into. And even if it just raises awareness, but we've had high school students, we've had adults, and it is a good program for our state.
Awesome, thank you.
And hey, Kyle, this is Doc. Yeah, our first round here, we only had a couple EMT students. This time, Eric Schuth, our paramedic that's running the program, a lot better recruiter than I am. He's got 12 or 13 ready to go students that are taking the course and attending, and that will be a very significant change in having that number of new EMTs in Spink County.
Absolutely, that's outstanding. Great number. All right, anybody else? Last call, keep answering questions. If nobody else has anything tonight, we will call it a night. Are we good, Michaela, on everything?
Yes, yep. Awesome. Thank you, Kyle.
Yeah, you bet. All right, everybody, thanks a lot. Again, real quick, before you sign off, we will not be meeting on October 27th due to the South Dakota EMS conference. We will be meeting on November 3rd. Michaela?
Let's see. Yes, November 3rd.
Okay,
And that'll
November.
diabetic emergencies.
Outstanding. So make sure you get registered for the conference if you're planning on going, and we will see you all November 3rd. Have a great evening and stay safe.